Good evening, students. Good evening, everyone. Please confirm if the audio and video are fine. If you can hear me. So once you confirm, I'll start the session. So I welcome you all to the Oral Surgery MDS 360 degrees session on YouTube. So essentially we will be discussing questions from trauma today, both mandible fractures as well as maxillary fractures. Okay, so I have a few questions. I have about 12 questions for you all. You can put down your answers in the chat box, in the live chat box. If you have any doubts, you can put those also in the chat box. I'll be answering your doubts as well. And while you're answering your questions, please answer along with the question number so that I am aware of which question you have answered. Okay. And before we move forward, I have a few announcements for you all at the end of the session. So please stick around till the end of the session. Few important announcements for all of you who are preparing for November INI as well as NEET MDS 2026. So let's get started. Coming to our first question of the session today. It says a child with parasymphysis fracture with no mobility and it does not involve the teeth is managed by A. Circummandibular wiring with cap splint, B. IMF, C. Diet restriction and observation for 2 to 3 weeks, and D. Open reduction. So what would be the answer here? Please put down your answers in the live chat box, and also please write the question number that you are answering. Okay, I have one answer. Anyone else wants to answer? Please don't be afraid of putting down the wrong answer in the chat box. This is not your exam. Alright, these are your practice MCQs. This is where you will correct yourselves if you are answering actively, irrespective of the fact whether it's the correct answer or the wrong answer. If you're participating actively, putting down your questions, interacting actively, you will retain things better. Okay, so I have one answer and the person says option A. Alright, now let us look at the question. What does it say? What does it point towards? I'll tell you how to read the question, how to take out the keywords, how to judge what the question is actually trying to tell you. Now let's see. It says a child. So we get to know that it's a pediatric patient. Okay, with parasymphysis fracture. The region of the fracture is also mentioned. Okay, I have another option, another answer from J. Okay, with no mobility. So this is important. There is no mobility and does not involve the teeth. Does not involve the teeth. This is important. Does not involve the teeth. So if you this question is suggesting that it is a kind of an incomplete fracture. It is a kind of an incomplete fracture. So incomplete fracture is also known as a green stick fracture. So the question is sort of pointing towards that the fracture is a incomplete fracture or green stick fracture. So in that scenario, the best answer here is diet restriction and observation for 2 to 3 weeks. Alright, this is the correct answer. Let us see what are green stick fractures. The next slide, a few important points regarding green stick fractures. So these are basically incomplete fractures, like I just told you. Only single cortex is involved. Alright, seen in pediatric patients due to elastic bones, and the treatment is very important. No active intervention is required. Alright, you don't need to do anything actively. You can give the patient semi-solid diet and observe. Observe to see if there, in a few weeks, if there is any displacement or if the fracture line has traveled or involved the other cortex. So you just keep the patient on soft diet and observe. So I have a picture here, I'll zoom out. This is a green stick fracture. If you see, only one cortex, that is the lingual cortex, is involved. Alright, lingual cortex is fractured. This is a CT scan, axial view of the mandible. It is showing a green stick fracture. Lingual cortex is involved and buccal cortex is intact. Okay, the buccal cortex is intact. So that is a visual for a green stick fracture. Coming to the next question, question 2. Identify the fracture marked in the given radiograph. What would be the best treatment for the same? So the options are A, horizontally favorable fracture, IMF. Option B, horizontally unfavorable fracture, ORIF with transosseous wiring. Option C, horizontally favorable fracture, soft diet and observation. Option D, horizontally unfavorable fracture, ORIF with rigid bone fixation. So what would be the answer here? Amongst A, B, C and D, look at the radiograph carefully. See where the arrow is pointing towards. Try to interpret the kind of fracture and what would be your treatment plan. Please put on your answers in the live chat box. Even if you're not confident, please answer. Okay, I have one answer. Rest. Okay, I have another answer from Master Key. Okay, now let's discuss this question. I'm zooming out the radiograph. Let us see. So if you see here, the first thing that you see, that this is a angle region fracture. Okay, I'll just erase this. This is just to help you trace the fracture line. So this is an angle region fracture. Okay, and if you see there is a step deformity. There is a step deformity. Okay, if you see this fragment from the radiograph, you can make out that it is superiorly displaced. This fragment is superiorly displaced. Okay, and if you trace the fracture line, I have told you in my class also, when we are talking in terms of horizontally favorable and unfavorable fractures, we trace the fracture line from the superior aspect to the inferior border, alright, or from the superior border to the inferior border. So if you trace this fracture line from the superior border to the inferior border, the fracture line is backwards or posterior. So please remember, you always have to, when we are speaking in terms of horizontally unfavorable or favorable, we have to always trace the fracture line from the superior border to the inferior border. Okay, so these are these information you get from the picture. So now, looking at the fracture line, it is a horizontally unfavorable fracture because there is displacement and the fracture line is backwards or posterior. Alright, now to counteract this muscle pull or the action of muscle resulting in displacement of the fracture fragment, what you will do? You will do a open reduction and internal fixation. Alright, ideally in this scenario, you can go with Champy's mini plates, but that is not in the option. So the best option that we have here is horizontally unfavorable fracture. You will treat it with open reduction internal fixation with rigid bone fixation. Okay, ideally had the one of the options mentioned, Champy's mini plates or just mini plates, that would be the best answer. Alright, so this is the correct answer. Lily, is it clear to you? Please let me know. Now I'll give you a very easy trick. How do you remember? So if the fracture line is forwards, that is, if the fracture line from the superior border to the inferior border travels anteriorly or travels forwards, then it becomes a favorable fracture. Alright, now favorable fracture has no displacement. Okay, there is no displacement, so you can manage that fracture conservatively. Okay, if there is no displacement, no gross disturbance in occlusion, you can manage a favorable fracture conservatively. Now if the fracture line is backwards is bad, that means D for displaced. Alright, D for displaced. Now whenever you have to treat a displaced or unfavorable, this becomes your unfavorable. Alright, you will always go for open reduction and internal fixation. Okay, fine. Now I have a question from Master Key, and it says, please also tell the location of application of mini plates. Okay, I'll tell the location of application of mini plates. Now, ideally, according to Champy's principles of osteosynthesis for angle fracture, we will just see the angle fracture because otherwise we will go beyond the topic. We'll just see for angle fracture. Okay, Champy says that ideal is one plate along the external oblique ridge. Ideal is one mini plate along the external oblique ridge. Now, clinically, situations can vary. Alright. Clinically, it may so happen that you have placed one mini plate along the external oblique ridge, but there can be still gap at the inferior border. So if you can feel a gap at the inferior border, you will put another plate. Okay. Sometimes the displacement at the inferior border is way too much and the superior border is intact, or they are in contact. So you can go for one plate at the inferior border. Excuse me. Okay. Or you can go in for a rigid recon plate if there is loss of bone. Okay. Ideal is one mini plate at the external oblique ridge. You can put two depending on the clinical scenario. Alright. Or you can put one at the lower border, or you can put one between the upper border and lower border depending on how your fracture is displaced. That you judge clinically and on the table. Alright. Is it clear to you, master key? I hope it is clear. I'll just erase this so that when you come back, you only see the relevant, when you come back to this video, you only see the relevant markings that are required. Please let me know if your doubt is clear. Also, Lily, please let me know if you have understood the correct answer. Coming to the third question, post-auricular ecchymosis in cases of fracture of the base of skull is called A. Battle sign, B. Tinel sign, C. Trossius sign, and D. Nikolsky's sign. Please answer this question. Okay, very good. That's great, you have understood. Okay, so yes, the correct answer here is battle sign. So all of you have got this correct. Very good. The correct answer here is battle sign. Just a few important points regarding battle sign and a visual, and then we move forward. So battle sign is basically ecchymosis of the mastoid region or region behind the ear, also known as post-auricular. Okay. Now the next point is very important. It is most commonly seen in base of skull fracture, followed by middle cranial fossa fracture, followed by petrous temporal bone fracture. You have to remember this order for answering, and you have to follow this order for answering your question. Okay. It can be associated with condylar fracture as well occasionally. Okay. So for us, why this is important? This can be associated with condylar fracture occasionally, and some authors suggest that this ecchymosis is apparent or is more visible 36 hours after injury. Please remember. Alright, and this is your visual. Post-auricular ecchymosis, mastoid region ecchymosis, it will be seen in this region, behind the ear. Okay, so that is your battle sign. Coming to question number 4. In fracture of atrophic mandible with bone loss, what is the best treatment? Option A, bone grafting and load bearing. Option B, bone grafting and load sharing. C, reconstruction plates, and D, gunning splint. So please answer this question. Also, I request all of you to put the question number along with your answer while answering. Okay, I have a few answers. Very good. Now, let us read what the question is trying to tell us. Okay, the question says atrophic mandible. That means resorbed mandible, thin atrophic ridges with bone loss. With bone loss. So that means there is a defect. Okay, there is a defect. So let us see if we have to. This is the bone. Okay, this is the bone. If there's a fracture but there is no defect, all right, but when there is a fracture and there is a gap between the two fracture segments, that means there is bone loss, there is defect. Now you have to bridge this defect. Okay, you have to fill up the defect between two segments. So you will do a bone graft. You will do a bone graft and you will give load bearing so that your fixation device takes upon the load on itself. Okay, so the correct answer is bone grafting and load bearing fixation. Bone grafting and load bearing fixation. All right, so reconstruction plates also you can use for atrophic mandible, but not when there is a bone loss. And gunning splints also you can use, but not when there is bone loss. All right, so you have to carefully read what the question is trying to tell you. Okay, is it understood? Lily, I hope the question is now understood to you and to everyone else also. Please let me know if you've understood or if there are any doubts. Coming to question number 5. A fracture at angle of mandible in a young adult with extraction of tooth from fracture line should be immobilized for an average of A. 3 weeks, B. 6 weeks, C. 9 weeks, and D. 12 weeks. Please let me know the answer to this question. Any more answers? So before we go to the answer of this question, let us understand a few rules regarding IMF. These are very important. Please take a screenshot of them. This you have to remember so that you can answer your questions correctly in the exam. All right. Now, let's see what the rule says. The rule says a young adult with fracture of angle. Young adult with fracture of angle receiving early treatment in which tooth was removed from fracture line. Okay, this is 3 weeks of immobilization. Okay, this is very important. This is the baseline. Then on 3 weeks, you either subtract or you add, depending on how the scenario is deviated from this ideal scenario. So this is taken as the ideal scenario. Young adult, fracture of angle, who receives early treatment and in which tooth is removed from fracture line. 3 weeks. This is your baseline. Now whatever deviations are done on this 3 weeks of immobilization. Okay. So in case you retain a tooth in fracture line, you add 1 week. So if you retain a tooth, you add 1 week to 3 weeks. Okay. there is fracture at the symphysis, you add another week. Okay, if the age of the patient is 40 years or more, you add 1 week or 2 weeks. Now, how to decide whether you add 1 week or 2 week? So, if the patient is between 40 to 50, no comorbidities or no systemic illnesses, you will add 1 week. Okay. Good evening, Grits. If the patient is 40 years and there is systemic disease illness, you will add 2 weeks. Okay. If the patient is above 50 years, you will add 1 week. You will add, 2 weeks. Please note, above 50 years, you will add 2 weeks. Even if there are no systemic illnesses. Alright. Now, why higher number with increased age? I'll just push this aside. Why? Because systemic illnesses delay healing. So, we will keep the IMF for longer duration. And with increased age, the healing capacity or recovery of the body is reduced or is slower. So you add or you keep the IMF for longer duration. I hope it is clear. Okay. And if it is a pediatric patient or it's a child patient, you will subtract or you will minus 1 week from your duration of IMF. Now let us see a 40-year-old patient. I'll solve this question for you so you understand it better. A 40-year-old patient with symphysis fracture. So you have taken 3 as your baseline. It says 40 years. You will add 1 for 40 years. It says symphysis fracture. You will add another 1 week. It says whose tooth in fracture line was retained. What would be the duration of IMF? So you have retained the tooth. So here the answer would be 6 weeks. Okay, in this scenario the answer would be 6 weeks. Now let's go back to our question. Fracture at angle of mandible in a young adult with extraction of tooth from fracture line. It should be immobilized for what duration? The answer is 3 weeks. Okay, fine. Jatin, have you understood? Please tell me if this is clear to everyone. Okay, shall we move ahead? Coming to the next question, question 6. Which of the following is not a goal of fracture management? A. Early return to function. B. Anatomic reduction and stabilization of fractures. C. Establish and preserve occlusion. And D. Functional reduction and fixation of fracture. Okay, very good. Rest anyone, if you have any doubts in the rules of IMF, you can let me know. So we've come to question number 6. Please answer this. Okay, so the question is saying, please note, the question is saying not a goal. That means what we do not want to achieve during fracture management, or which is not our goal or not our priority. So the correct answer is functional reduction and fixation of fracture. It is always anatomic reduction. Okay, it is always anatomic reduction while restoring function. It's never functional reduction, because if you do functional reduction, you might not achieve anatomic reduction. A step may still remain or mobility may still remain. So the goal is always anatomic reduction. Now, I just want you to note down these 4 very important points. So, there is an organization known as AO or ASIF, alright, which stands for the Swiss Association for Study of Internal Fixation. In late 1950s, they gave the principles in fracture management. Alright, in the late 1950s, they gave principles of fracture management. And they said that 4 things are of utmost importance to us that we have to achieve while reducing our fractures, or these are the 4 goals that we have to achieve. First is accurate anatomic reduction. Second is atraumatic operative technique, preserving the vitality of bone and soft tissues. Alright, so while reduction, you have to make sure that you do not cause further injury to the bone. Alright, or you do not cause devitalization of the bone. Okay, the third one is rigid internal fixation that produces a stable or mechanically stable skeletal unit. That means there has to be no mobility. The skeletal unit that you are restoring has to be stable. Okay, avoidance of soft tissue damage and fracture disease by allowing early, active, pain-free mobilization of the skeletal unit. So please note, early, active, pain-free mobilization of the skeletal unit. So the goal is to reduce fracture disease related complications, to reduce soft tissue damage, and to allow early, active and pain-free mobilization and skeletal unit. Please take note of these points, add it to your notes or take a screenshot of this. Okay. So, Lily, SR, I hope you have understood the correct answer. Coming to the next question. Question 7. A 28 years old road traffic accident patient was brought to hospital with severe mid-face injuries and bleeding. Patient had an impacted maxilla. The operator stands behind the patient and uses the given instrument to disimpact the maxilla. Identify the instrument. Option A says Hayton-Williams forceps, smooth curve goes into the nasal cavity and sharper curve goes into the mouth. B. Rose disimpaction forceps, smooth curve goes into the nasal cavity and sharper curve goes into the mouth. C. Hayton-Williams forceps, sharper curve goes into the nasal cavity, smoother curve goes into the mouth. D. Rose disimpaction forceps, sharper curve goes into the nasal cavity and smoother curve goes into the mouth. So please answer this question. Okay, one answer. Anyone else? See the instrument, try to identify the instrument. Okay, so I'll zoom out. This is the smoother curve. Okay. And this is the sharper curve. Okay. So this is your Rose disimpaction forceps. We'll see the uses in the next slide. Now, to remember, this sharper curve goes into the oral cavity, and this sharpness is given to accommodate incisors. Alright, I have a few visuals in the next slide. So please remember, why does the smoother curve go into the nasal cavity and why sharper goes into the oral cavity. Once you understand the reasoning behind it, you will never forget it. So try to remember. Okay, so I'll tell you the answer before we move forward. So the correct answer is B. Rose disimpaction forceps, smooth curve goes into the nasal cavity and sharp curve goes into the mouth or the oral cavity. So this is the correct answer. Okay, just see this here, sharper curve to accommodate the incisors. This one, follow the pen, and smoother curve into the nasal cavity. Okay, this is your Rose disimpaction forceps. This also is your Rose disimpaction forceps. Here the operator is standing behind the patient. Okay, and this one is Hayton-Williams. This one is Hayton-Williams. This, it goes and engages the tuberosity area. Hayton-Williams, it goes and engages the tuberosity area. Okay, so you can come back and go through this. Alright, so Rose maxillary disimpaction forceps, a few points between these two, and Hayton-Williams forceps. So it is a paired instrument. So in Rose you will have a left and a right sided instrument. Hayton-Williams is a single instrument, there is no side associated with it. Okay. Operator stands behind the patient in Rose while using the Rose disimpaction forceps, but it is not necessary for the operator to stand behind the patient while using a Hayton-Williams forceps. Alright, it is not necessary. Usually, mostly we stand behind, but it is not necessary. The uses for Rose disimpaction forceps are maxillary disimpaction. In Hayton-Williams, there are two uses. One is maxillary disimpaction and two is reduction of mid-palatal split fracture. So let me go back. So if there is a palatal fracture here, it is also used to reduce this palatal fracture. Okay, if there's a palatal fracture, it is used to reduce the mid-palatal fracture, reduce the mid-palatal split. Okay, due to its bracing effect on the maxilla, it engages the maxilla like a brace. Okay. Coming to question 8, identify the triage need of the patient according to the band on the patient's wrist in the given image. A, requires immediate treatment. B, can be discharged after first aid. C, unresponsive patient. D, patient requires treatment, however, delay in treatment is possible. What would be the answer to question number 8? Lily, I hope you have understood the previous question, question number 7. The answer to that. Please let me know. Okay, I have one answer. So the correct answer is patient requires treatment, however delay in treatment is possible. Okay, we will quickly go through triage. You can take a screenshot of this table here. So in this table I have mentioned the triage categories, the treatment needs and the examples. Okay, yes, I'm very happy all of you have got this answer correct. Very good. Ritz, Master Key, Jatin and SR. So triage category red means immediate treatment needs. Alright, these patients require immediate treatment for their survival. Alright, and they are addressed first. So they are an emergency or they are urgent. They require urgent care. So the examples are patients with airway obstruction or patients with external hemorrhage from legs. Now, what do you mean by external hemorrhage from legs? Legs have long bones. Alright. So whenever there is hemorrhage from long bones, alright, one, the patient will go into shock very fast, and second, they have a risk of fat embolism. Let us not go into the mechanism of how long bone fracture cause fat embolism. Just remember these 2 points. They will get the patient into hemorrhagic shock very fast, and second, the chance of fat embolism. Alright, now fat embolism can go and obstruct your coronary and pulmonary circulation. That's why they are an emergency. The second triage category is yellow. Alright, this is the delayed treatment group. These patients require treatment, however delay in their treatment is possible because they do not have life-threatening injuries. Okay, so a mandible fracture is categorized as yellow. But however, when there is a mandible fracture with airway obstruction or respiratory distress, it will be categorized as triage category red. So please note. The next is green. Alright, so these are the minimal treatment groups. You can just maybe give first aid to these patients. These patients are ambulatory patients. They're moving around on their own. They just have some abrasions, some cuts. So they can be discharged from the accident site, or they can be discharged from the hospital after you give them the treatment. Alright, example, suturing of soft tissue wounds. Fine. Black category is given to such patients who have very, very poor prognosis, who are not going to survive. Their chances of survival is very less. Alright, and who have very extensive injuries, who are not breathing, who their vitals are not recordable, they're pulseless. So such patients will eventually pass away. So they are categorized as black. So the example is patients with severe brain injury. I've taken triage in detail in my class. You can go and revise from there. Okay. Now coming on to the next question, which is the immediate danger to patient with severe facial injuries. A, bleeding, B, associated fracture of spine, C, infection, or D, respiratory danger. So what would be the answer here? Answer to question number 9. The correct answer here is respiratory. So whenever there are severe facial injuries, okay, now there can be blood or debris in the upper airway, which can lead to a respiratory compromise. There can be displacement of the fractures in such a way that it can lead to respiratory compromise. Okay, so the immediate thing that you have to first secure for a patient with either head injury or maxillofacial injuries, head injury or maxillofacial injuries, the first thing that you have to assess and secure is the airway. If you remember ABC, so first always is the airway or the associated respiratory danger that you have to secure first. I hope this is clear to all of you. Ritz, I hope the doubt is clear. Coming to question number 10. In fracture of zygomatic maxillary arch, most definite checkpoint for zygomatic arch reduction is A. Click on reduction, B. Inferior orbital rim symmetry on both the halves, C. Zygomatic buttress symmetry on right and left halves, and D. Zygomatic arch symmetry on right and left halves. What would be the question to, what would be the answer to question number 10? So in the previous question, you always take control of the airway first and then control the cervical spine. Okay. In the previous question, the airway respiratory question, you always secure the airway and then control the cervical spine. And you secure the airway in such a way that you do not cause any movement at the cervical spine. Okay. Please tell me the answer to question number 10. Any more answers? So a few important points, please note them. I have mentioned in my class also. So best indicator for zygomatic complex reduction. If the question, now you have to look out for keywords. Okay, so if the question asks which is the buttress, which is the best indicator for zygomatic or ZMC reduction, if they ask you in terms of buttress, you will say it is zygomatico-maxillary buttress or ZM buttress. These are all potential question points. If they ask you which suture will you check or which suture is the best indicator for ZMC complex reduction, the answer is phenozygomatic suture and it is present in the lateral wall of orbit. Okay. If they ask you the best indicator for zygomatic arch reduction, please remember it is symmetry of arches. It is not click or it is not the sound. Why? Because even when you're moving the bones, when you're reducing the bones, any wrong movement will also give you a grating or a clicking sound. Alright? So that does not necessarily signify that you have reduced. Any click or grating means the bones are moving against each other. Click may also signify that the bones have now overlapped each other. Okay, so it's never the click, it is always the symmetry of arches. Now in your question, if they do not mention buttress, suture or arch, you will still mark symmetry of arches. Okay, if no keywords are given in your question, you will mark symmetry of arches. Alright, so zygomatic arch symmetry on right and left halves is the correct answer. Okay. Now coming to question number 12. Gillies approach is used in A. Open reduction of zygomatic fracture, B. Mandible, C. Closed reduction of zygomatic fracture, and D. None of the above. So what would be the answer here? This is an easier question. So please let me know. So please stick around till the end. This is the second last question. I have a few very important announcements to make, and those are especially going to benefit you all for the upcoming examinations. Okay, so the correct answer is closed reduction of zygomatic fracture. Very good. Now, Gillies is a closed approach. We all know that. Although there is an incision, we do place an incision, but we do not directly visualize the fracture line. Hence, it is a closed reduction. We, in spite of giving a incision, we are reducing the fracture in indirect vision or not under direct vision. Alright, it is also known as temporal area or temporal fossa approach. Gillies incision is given at an angle. This is very important. All 3 points are question points. 45-degree angulation to the zygomatic arch. Alright, and approx 2.5 centimeter above the helix of the ear. Some books mention helix and some books mention tragus. Alright, mostly it is taken from the helix of the ear clinically when we are reducing it. So this is how you place the incision, and why these two things are important: 45-degree angulation and 2.5 centimeter above the ear, so that you place your incision between the bifurcation of superficial temporal artery, so that you do not injure this blood vessel. That is why you place this incision in this particular fashion. And insertion of the elevator is between temporalis muscle and temporal fascia. And I have explained this in detail in my class. Why do we insert the elevator between the muscle and the fascia? Okay. Coming to the last question for the session. Lefort 3 fracture is the same as A. Craniofacial disjunction, B. Guerin's fracture, C. Pyramidal fracture, D. None of the above. This is also a very simple question. Please answer, all of you. Very good. I want all of you who are viewing live to answer this question. Yes, very good. The correct answer is craniofacial disjunction. The correct answer is craniofacial disjunction. Okay. Very quickly we'll see the visual for Lefort 3. If you see, it extends from the frontonasal region, involves the medial wall of the orbit, floor of the orbit, lateral wall of the orbit, frontozygomatic suture, and also fractures the zygomatic arches and travels downwards to fracture the pterygoid plate. Okay. So if you see, the maxilla is completely separated from the cranium. So it is known as craniofacial disjunction. Okay. So it is known as a high level fracture because it is the highest level in all the Lefort lines. suprazygomatic fracture because the fracture line is above the zygomatico-maxillary buttress. This is your ZM buttress. Okay, Leafort 1 and Leafort 2 fracture lines travel below the buttress, so they will be subzygomatic fracture lines. Transverse fracture of maxilla, transverse, alright, transverse fracture of maxilla, and craniofacial disjunction, that is middle third of the face or maxilla gets detached from the cranium or separated from the cranium. This is very, very important question point. Okay, with that we are over with the questions for today. Now we have AIIMS coming up on 9th of November. So from the 1st of September, we will be discussing AIIMS PYQs that are previous year's questions. So we will be having a master class starting from 1st September up till 9th November. We will be having AIIMS PYQ master class. Alright, we will be discussing important past questions, past topics, important pointers which will help you with your exams. So we'll be discussing all past papers of past 2 to 3 years most importantly. Alright, so please attend these sessions. They are for your benefit so that you can give AIIMS with confidence, because each and every year seats in AIIMS for MDS are increasing. Alright, seats between for AIIMS especially for MDS are increasing. Okay, the next thing that I want to announce is that we will be having a computer based test, all India computer based test before NEET MDS 2026. The date given on your screen is tentative. Once the date for NEET MDS 2026 is announced, we will be altering this date as per the date of NEET 2026. So this will be a computer based test. This test will be conducted in 25 cities across India. You will be allotted a center. You can go to the center, give your exam, and it will be complete simulation of your exam environment, of the final day exam environment. You will get an admit card. You'll get a admit card or a exam ticket. You can register for this NEET MDS CBT. Alright, on the DAMS Alpha app. It is open to everyone, Damsonians as well as non-Damsonians. You can download the DAMS Alpha app and register for this All India NEET MDS CBT from the app. Okay, you can also tell your friends to give this exam. Okay, and like I said, it will be a computer based exam. You will be given a hall ticket. You will have to go to the exam center and give your exam on the computer, just like how you give for your actual exam. All right, so once you go to the app, all right, in the lower right hand corner there is a CBT tab here. CBT tab, you can click on that and you can register. Okay, and this is the schedule for the upcoming week, the MCQ edition, and from 1st September we will be having the AIIMS PYQ masterclass. Alright, so I have a few doubts. I'll take them. Ma'am, can you explain how to differentiate between deviated, dislocated, displaced TMJ? Ritz, my next class, that is day after tomorrow, I'll be taking questions on TMJ. I'll tell you the difference, how to differentiate between these in detail in that class. Okay, my class day after tomorrow, that is 27th August, I'll be doing, today we've done trauma. Day after tomorrow, we'll be doing TMJ questions. In that class, I will tell you. I have a few questions on this particular thing, so you will understand better. Okay. Master key. If an unconscious patient with head injury presents in emergency, what things shall be done first, or is more important, a corneal reflex test or pupillary response? See, the most important is first you secure the airway, then you'll see the GCS. So now the GCS is your eye opening response. All right, that is eye opening response. And after that, the most important is pupillary response. All right, pupillary response is most important. Corneal reflex test usually is not important. So ABC, and then followed by assessing the GCS of the patient, and then finally seeing for the pupillary light reflex or pupillary response. I hope your doubt is clear, Master Key. If there are any other doubts, you can let me know. So please give us a thumbs up if you're liking these sessions. You can comment down. Even after the sessions are over, you can revisit the sessions. You can comment down any queries that you have after the sessions are over. You can subscribe to our channel and share the sessions with all your other friends so that everyone benefits from it. I hope your doubt is clear, masterclass. Please let me know, then we'll wind up this session. Okay. Thank you for joining in, students. Good night.